specialist and a neurologist in our hub today. So to my left, I have Professor Kristen Stafford, who's a specialist in HIV and aging, and she's an epidemiologist by profession. We also have, let me just move the camera. We also have Professor Denise Orwig to my left. Prof. Denise Orwig is a gerontologist by profession. And to my right over here, great. And to my right, we have our very own neurologist and our dementia specialist, Dr. Mata Mata. Thank you all for joining us. And we also have Dr. Galant Wanza, on my right, who is our infectious disease registrar. Thank you for joining in, and thank you, Network, for joining in on the ECHO platform today. So without wasting much time, just a few house rules. Let's ensure our microphones are on mute. And if we have any questions, kindly raise your hands or post in the chat box, and we should be able to attend to them. I'd also like to acknowledge our panelists. We have Professor Cassidy Klassen from UMB, who's joined online. Thanks, Prof. Cassidy. We have Dr. Sulanji Sivile and Dr. Somachi, who are infectious disease physicians, and will join our panel. So without taking much of your time, we're going to start with a case presentation, followed by a didactic presentation. I will take you through the case presentation, and we'll have a Q&A. We will jump into the rest of the session. Okay, so again, just a reminder of house rules. Kindly ensure your microphones are on mute. Thank you. Great. So okay, so this is a case of an 8-year-old male who's hypertensive, has benign prostatic hypertrophy, and is a newly diagnosed RVDR patient, and had never ever tested in the past 10 years, despite being treated as an outpatient in our clinic here. So this patient presented with weakness, fatigue, weight loss, and sweats for a 6 weeks duration, had an occasional productive non-blood tinged cough, and had no lower limb swelling, paroxysmal nocturnal dyspnea or orthopnea, and reported no fevers during this illness. Past drug history, he was taking his tamsulosin for his BPH and his amlodipine for his hypertension, but was non-compliant on further probing. He had a non-remarkable past surgical history, his social history. He has been married to 3 women and has 17 children of his own. Unfortunately, 2 of his wives were deceased, and 7 of his children were deceased. On further probing of his sexual history, he said he was sexually active, but was a little cagey to give further history in regards to that. He does smoke tobacco and takes locally brewed spirits, and previously was a farmer who currently was being taken care by a maid, and had his children come in and out just to visit him. So on physical exam, he was oriented to time, place, and person. He was afebrile to touch. He had generalized lymphadenopathy. He was mildly pale, but not jaundiced, had a normal JVP with no neck stiffness. His oral cavity had some thrush, but no KS lesions of note. On his skin, he had a maculopapular rash. And on examination of the systems, his chest, he had bronchial breath sounds, more in the upper and mid zones. His S1 and S2 was normal and regular. His abdomen, he had central obesity, couldn't appreciate any organomegaly, and he had no edema on further exam. His vitals, his BP was 156/94, had a pulse of 92. His temperature was stable at 36.2. He had an elevated respiratory rate at 22, and SpO2 ranging between 93 and 95 on room air. Some of the bed tests we did at that point, we carried out a urine lamp, which turned out positive. A urinalysis, bedside urinalysis where leukocytes were present, and a random blood sugar that revealed a sugar of 7.2. So made an assessment of an 80-year-old male, known hypertensive, and benign prostatic hypertrophy patient who was a newly diagnosed person living with HIV who presented with weakness, fatigue, and constitutional symptoms for 6 weeks, with a very relevant social history revealing multiple sexual partners, and a physical exam revealing generalized lymphadenopathy, oral thrush, and bronchial breath sounds on chest exam. So at this point, we started managing as a newly diagnosed older patient living with HIV, with advanced HIV disease, with concerns for disseminated TB, oral candidiasis, and uncontrolled hypertension. So some of the investigations we then got, he had a full blood count that was done that revealed a normocytic normochromic anemia. His liver function and kidney function test panels were essentially normal. He had a serum cryptococcal antigen test that was negative, as well as a toxoplasma antigen that was negative. A chest X-ray was obtained that revealed bilateral hilar lymphadenopathy with no cavitations noted, and a mild right-sided pleural effusion. And on his cholesterol tests, we found he had some dyslipidemia. So in terms of his progress during his hospital stay, he was commenced on anti-TB drugs and B6, and then had delayed initiation of ART, which was 7 days later, was commenced on a statin because of the dyslipidemia, as well as his age, and then also his BP control was optimized. And the patient was then discharged from inpatient care and linked to ART and TB services. So that's the end of the case presentation. And at the end of that, we have these questions, which is more of a food for thought. This is to the network. Do we need to increase screening in outpatient clinics to pick up recipients of care like these? Remember, from our patient, this patient has been going to the outpatient clinic for over 10 years, attending the BPH clinics and hypertensive clinics, but we haven't been regularly screening him for HIV. Should we increase screening? Also, should we educate our older people living with HIV about PrEP services? Remember, this is an 80-year-old man. He's still sexually active. He is widowed. Do we need to provide PrEP services to them? And lastly, do we need a specialized ART clinic for our older people living with HIV in our setting, given the whole complexity, as we now have an increase in the life expectancy of people living with HIV on highly active antiretroviral treatment? Okay, so that ends my presentation. So I'm going to open up for a very quick discussion before we jump into the didactic. Would like to get your opinion, your questions regarding this case. So kindly post in the chat box or raise your hands and should be able to attend to them. Okay, we have. Okay, so if you've got any questions, kindly raise your hands or you can post in the chat box. Okay, so far we don't have any questions yet. Maybe as a team that's in here, so we've just been joined by Dr. Mundia Mutuma, who's our infectious disease specialist, and also our specialist in PrEP services. Thank you for joining us, Dr. Mundia. That's her there.
Thank you. Good afternoon, everyone. Good afternoon.
Great.
Welcome. Yes.
All right. So we do have a few questions on our screen. regarding the same patient. So do we need to increase screening in outpatient clinics to pick up recipients of care that get missed?
You have somebody in the chat.
Would we need to educate our older people living with HIV about PrEP services? And do we need a specialized ART clinic for our older people living with HIV, given the complexity, as we now have an increase in the life expectancy? So we do have Mufasa. Okay, great. So we do have Mufasa. Thank you. He says yes to all. And Aksan Miti, who comments sexually active at 80 years is a surprise. Thanks for those.
That's interesting, though. I think that's a common conception. People think that older people are not sexually active. And I love that you did this case today, because in the didactic, one of the things I'm going to be talking about is screening and testing for HIV in older people, and about sexual partnerships among older people based on data that we have from Zambia.
Right.
So I think this is the critical question. How many of these people do you, so here's one case of one 80-year-old man, but how frequently are you seeing this these days? Older people presenting and testing for the first time with HIV?
Great question. So based at UTH, from our outpatient and inpatient, we have been seeing a couple, probably in a week on your admissions, you'd see at least maybe 2 to 3 elderly patients coming in with a new diagnosis of HIV.
Yeah.
Which is quite concerning.
Yeah. You have another really good comment there.
Yeah, thank you for this comment. It says, we have a gap with HIV status for the elderly people, so we do need to increase screening, especially in men. Thank you for that comment.
Yeah, this is another thing I'm going to touch on in the didactic today. It's a timely comment.
Right. And then we've got a comment from Mumbi Musosha from LPHO. Thanks for that. Any support to the family to also check on their status? How do we handle disclosure issues? And a comment from GIF, the sexually active is just in older males or even older females.
Even in older females.
Great. So sexually active is both males and females. Thank you, Dr. Musosha, for this question. Any support to the family to also check the status? So basically, this recipient of care that came to us was living alone, was taken care by a maid, and was widowed, so was not living with anybody at that point of time, right? How did we handle the disclosure issues? We obviously tested and counseled him, and it was up to him to reveal his clinical status to the family. So we couldn't really go ahead and discuss further things with the family apart from him.
But I think it's important, again, to link this to the didactic. We're going to talk, remember, this is an older man who was widowed, who was living with a young woman taking care of him, correct?
Yes.
Yeah.
Yes.
So we're going to talk a little bit also about intergenerational partnerships and their role in the continued epidemic in Zambia.
Great. Thank you. So thank you for those comments. We're going to take these few last comments and then move on to the didactics. So we've got a comment from Vanek Chimiku. Thank you for that. Vanek says yes to all the questions. Most older people help out in childbirth without proper gear. By educating them, it will help them understand that HIV is beyond sex. And that's an excellent comment. Especially in the communities, we still do have childbirth, community-based volunteers who are not actually engaged in healthcare, but volunteer to give to help with childbirth, which is very important. And then Dr. Simpungwe, thanks for your comment. Dr. Naik, do you find that inquest around sexual activity with older patients usually results in KG responses, as with this patient? And yes, usually ends up in a very KG response. The patients would usually get into that fright, flight, fight mode when you asked this question, even on the side. I'm not sure what Dr. Mata's experience has been if coming across such. I'm going to ask Dr. Mata.
Sure. I think it depends on how the questions are asked and in what kind of situation the question is being asked. If you have built a relationship with the person in front of you and they can trust you to talk about certain things, it's surprising how often actually, even in patients I see in my clinic, the question about sex and sexuality does come up in terms of they want, even in the older age, they want to continue to be able to engage in sexual activity. It's just that they're not always comfortable to tell us the things that they want to tell us. So it's about how do we ask those questions and when do we ask those questions?
Great, thank you for that. I completely agree with your statement there. Okay, so I know we're running out of time. We'll quickly have to jump into the didactics, but there's a great conversation going on in the chat box. Lots of different opinions. We need to do index testing, including the MAID. We need to have specialized clinics for older people living with HIV and increase screening for this age group, especially that this case, the client presented with AHD. I agree with that. There's need to strengthen screening activities as well as NCDs. That's excellent. I'm sure Prof. Kristen is going to jump through that in her presentation. And geriatric medicine in HIV medicine must be embraced to offer better comprehensive HIV care for the elderly living with HIV, from prevention, diagnosis, but screening tools and financial support may be a challenge to offer better DSD models. I think that's you've put that really, really well. And I completely agree. I'm sure the rest agree. And lastly, we have from Dr. Chewe, already struggling to keep up with ART clinics. We are now talking integration. Having separate clinics for older people living with HIV can be very strenuous on the system at the moment. Yep, very, very true. Very, very true. And integration is the way. So I think it's something that would best help our recipients of care. All right. So thank you so much for this very fruitful discussion regarding this case. I'm now going to go on to, we're now going to go on to the didactic presentation for today. Just give me a second as I open it up there. Okay. Great. So now we're going to go into our didactic presentation, and we're honored to have Professor Kristen Stafford, who's an associate professor in epidemiology and public health. She's come to visit us all the way from the USA, from Maryland. She's a deputy director at the Center for International Health, Education, and Biosecurity at the Institute of Human Virology, University of Maryland School of Medicine. And once again, thank you so much for joining us today and giving us this very important talk along with Prof. Orwig and Dr. Mata.
Thank you for having me.
Yeah. So at this point, over to you.
Okay. Yeah. How do you want me to advance the slide?
I'll do it for you. Yeah. Okay. I'll do it from here.
Okay, great. So good afternoon, everyone. Thank you all so much. Mulibwanji, I hope everyone is well. I'm going to cover a few topics in broad detail today. Each of the things I'm going to cover could be an entire course all unto themselves. So I'm hoping more to stimulate conversation amongst your group, so you can talk about these things in the context of care in Zambia. So I'll talk a little bit about the demographic shift in HIV and some of the drivers of that shift in Zambia, as well as other similar countries. The implications of HIV infection and accelerated aging, HIV testing and prevention among older adults, which is a topic that just came up in the discussion, integrated care for multimorbidity, which also just came up in the discussion, and quality of life, the need for a fourth 95 in our metrics. So next slide. Let's talk a little bit about the demographic shift in HIV prevalence. So as all of you know, who are providers of HIV care, work in the clinics, you know that individuals with HIV have been surviving longer than they did 20 years ago when efforts were made to broadly scale HIV care and treatment in Zambia and other places in sub-Saharan Africa. Back in 2012, there was a model by Honteles. It was the best model we had at the time. And it predicted that by 2040, about 27% of all people with HIV in the world would be age 50 or older. So we're still a few years away from 2040, right? As of 2024, data from around the world has demonstrated that a third of all people with HIV are already 50 years or older. Most of the improvement in the gains that have come in the global epidemic have come from gains and improvements in Africa, that is home to the majority of the people living with HIV around the world, and have really driven this epidemiologic shift in the demographics of people living with HIV. I like to remind people, this was a model-based estimate, was wrong, but it's not wrong. All models are wrong. It's just some models are useful. What these models in 2012 could not predict were changes in guidelines, things like universal treatment, test and treat, improved case finding through partner and recency testing, advances in treatment and prevention, such as integrase inhibitors and PrEP, and the pace with which countries like Zambia, particularly in Africa, would scale these interventions. So the shift in, you can sometimes hear it called the graying of the epidemic, the silver tsunami, which is used less often these days. But this demographic shift of the majority of the prevalence moving to much older populations has happened far more rapidly than I think any of us could have anticipated. Next slide. So here's your first poll question. Do they actually hit the answers? Okay, great.
Okay, great.
We're going to hit the poll.
This is our first poll question, and I'm going to launch the question. So the question reads, the prevalence of HIV among adults aged 60 to 64 years in Zambia is dash than adults aged 25 to 29 years. So option A is lower, B higher, C the same. So the prevalence of HIV among adults aged 60 to 64 years in Zambia is lower, higher, or the same than adults aged 25 to 29. Okay, seeing some great response so far. This is amazing. Kindly continue responding to the question. The prevalence of HIV amongst adults aged 60 to 64 years in Zambia is lower, higher, or the same than adults aged 25 to 29 years. Okay, so this has been some great participation. I'm going to end the poll here now and sharing results with you. Prof. Kristin, we have 67% that have opted for option A being lower, 22% that opted for option B being higher, and 11% that have opted for option C the same. And I'm sure we'll learn more during this session.
We will. Thank you so much for participating in that. Let's go ahead to the next slide. The answer is that the prevalence of HIV in adults 60 to 64 is higher than adults aged 25 to 29 in Zambia. What you see on this slide are the results of your Zamfia 2016 and your Zamfia 2021, which are able to get you the prevalence of HIV in the entire population of Zambia. Across the x-axis on the bottom are 5-year age groups. On the y-axis is the HIV prevalence. This is weighted prevalence. So these are population level estimates. And as you can see, in 2021, your most recent Zamfia, the prevalence of HIV among adults 60 to 64 was hovering around 17%, whereas the prevalence of HIV among 25 to 29-year-olds is closer to 7%. Now, there's a lot of reasons for this. There are a lot more 25 to 29-year-olds in the country of Zambia than there are 60 to 64-year-olds. But this is also driven by people living longer with HIV. The dotted line is your results from 2016. The solid line is 2021. This shows the cohort effect. It's the demographics are marching to the right. So people who were 25 to 29 in 2016 were 30 to 34 in the 2021 survey. So if you follow that line across, you see a couple of things. One, the incidence of new infections among younger people decreased in that 5-year period. And this was published in the primary results of your Zamfia study. But you can also see the prevalence increasing in people aged 50 to 54. It's higher than that age group was 5 years earlier. That is both survival as well as new infections among that older population. On to the next slide. So why is HIV and aging important? Here's our poll question number 2.
So this brings us to a second poll question. And our second poll question reads, people with HIV have a higher risk of developing aging-related conditions than people without HIV of the same age. People with HIV have a higher risk of developing aging-related conditions than people without HIV of the same age. Option A being true and option B being false. Great participation. Let's all ensure we participate. Your responses remain anonymous. So people with HIV have a higher risk of developing aging-related conditions than people without HIV of the same age. True or false? Okay, some great responses so far.
That's great.
I'm gonna end the poll question here now. Okay, so again, great results. We've got 86% that have opted for true and 14% that have opted for false. And I'm sure we'll learn more in the next few slides.
Exactly. So
Yeah,
next slide,
great.
please.
Okay.
So I'm gonna give you the answer to that at the end of these next few slides. So what are the implications of aging with HIV? There have been studies for a while now emerging over the last decade or so from the US and Europe, and there's emerging evidence from Africa that has found accelerated biological aging. So aging at the cellular level, where someone is cellularly older than they are in terms of their chronological age. Higher rates of non-communicable diseases, hypertension, myocardial infarction, peripheral arterial disease, impaired renal function compared to the general population among people with HIV. Lower age at some cancer diagnosis, lung, anal, oral pharynx, kidney, and myeloma. Increased mortality and morbidity from non-AIDS related conditions, and higher physical and cognitive functional decline among people with HIV. Next slide. Now, the increased risk of these aging conditions, and this buries the lead a little bit in that I'm saying that the current answer is true, that people with HIV are at increased risk of some of these conditions, but I'm going to show you some slides that will demonstrate that this is still an evolving picture. We don't know in the current context whether this will continue to be true. But some likely mechanisms that have been identified for this increased risk of aging and this accelerated aging in people with HIV are things like immune activation, particularly at seroconversion. As you know, HIV only replicates in an activated cell. When someone seroconverts, there's massive amounts of immune activation and inflammation that occur as HIV rapidly replicates itself, which causes increased inflammation. So due to this HIV replication at and after infection, even with suppressed viral load on medication, successful therapy, there's still low-level viral replication that's occurring. Immunosenescence, so just due to natural aging, our immune systems get a little weaker as we all get older. There's a loss of naive T cells. That contributes to some of the accelerated aging we see. The metabolic effects of antiretroviral therapy, particularly some of the earlier generations of ART, had metabolic complications. These conditions may be exacerbated in low resource settings due to other acute or chronic infections, things like hepatitis B and C, malaria, TB, CMV, The prevalence of CMV is 95% among people with HIV compared to the general population, 82% among people without HIV. When you think of a child who is born with HIV, someone with perinatal infection, they're exposed to CMV before they're born and during their early gestation, far earlier than kids are normally exposed to CMV and acquire CMV, which could have implications on their cellular aging as well. And then helminth infections. Additionally, the impact of stigma cannot be overlooked. But the aging trajectories of people with HIV will likely differ based on the area of diagnosis. This is where people who answered true are mostly right now, and people who answered false may be predicting the future for us. So the duration of unsuppressed viral load prior to ART is one of the biggest drivers of this accelerated aging. I have been working in HIV for 30 years. So I started in the United States for 10 years before starting to work in sub-Saharan Africa in 2004. The guidelines have changed dramatically in that time. Here, when we first started rolling out antiretroviral therapy, when your government started rolling out antiretroviral therapy, we waited for people to develop AIDS. That was more of a research consideration, but there were still questions in terms of treatment. Do you treat early, and do you treat hard, or do you wait? Do you start people on therapy? Do you remove them? We've gone through these cycles, and those things will have an influence on what people's aging trajectories are for the rest of their life. So era of diagnosis is something important. There are a very large number of people in this country who have been on antiretroviral therapy for 10, 20, some even 30 years. Their aging might look very different than someone who is diagnosed today. They're diagnosed early with a competent immune system, and they're started on an integrase inhibitor. Their aging trajectory might be very, very different. There are accumulated toxicities due to previous TIs and PIs in particular, and these are only partially attenuated by switching to the newer regimens, the integrase inhibitors. There's also challenges with recurrent unsuppressed viral load. We know that interruptions in care are one of the biggest threats to maintaining epidemic control in Zambia, to achieving the targets that you will have because of viral rebound. These periods of suppression, viral rebound result in increases in inflammation and immune activation, and also accelerate biological aging. Next slide. We know that immune response to antiretroviral therapy is significantly attenuated following the initiation of ART as age increases. So the three panels on the right are from work that we did several years ago here in sub-Saharan Africa using longitudinal medical records and looking at the cumulative probabilities, this is the cumulative incidence of a person who started ART achieving a low normal CD4 cell count, so a CD4 cell count of 500 or higher. And we looked at this by age, but also what their baseline CD4 was. So we compared people by 10-year age groups, 20 to 29, 30 to 39, 40 to 49, by baseline CD4. So the first group was those with a CD4 of less than 200. And we looked at what their trajectory was. And as you can see by those lines, the dark line at the top on all three of those graphs is that youngest age group. They end up with the highest probability of achieving a low normal CD4 cell count, even though they started AIDS defined at less than 200. When you move up 201 to 349, you see the probability of achieving low normal, and this is by 4 years, goes up, and it goes up for every age group, but there's clear separation by decade. Same with people starting above 350. And now this study, I completed this study right before the rollout of Test and Start. So we'd have to look at what it looks like now with people starting with far more robust immune systems. But we know that as you get older, you have a loss of naive T cells, your immune function is diminished to a certain extent. And so you do not mount as robust a response to antiretroviral therapy, and it's demonstrated here. And the consequences of that are older people remain at risk for reactivation of tuberculosis, other opportunistic infections. They have more inflammation, more immune activation than younger people, which is also going to further accelerate their aging. And what we don't know are how repeated cycles of suppression and non-suppression impact the CD4 rebound instability. We looked at this just longitudinally. We didn't take into account whether people were cycling on and off therapy, but this was also at a time where we were measuring CD4 cell count. We've unfortunately stopped measuring CD4 cell count, which is understandable with resource constraints. But we don't know at this point if those peaks and valleys of CD4 rebound are going to get progressively lower and lower and lower. You think about a pendulum swinging. You start it swinging in it and it goes pretty well, but eventually, as atmosphere interacts on it, it's going to stop swinging, stop swinging, stop swinging. So what do repeated cycles of interruption do to older individuals on antiretroviral therapy? Next slide. And again, aging trajectories of people with HIV likely differ based on that. We went backwards. That's okay.
Oh,
There we go. Aging trajectories for people initiating INSTIs are going to need further investigation. So INSTIs have been shown to have superior suppression of HIV viral load. This may actually attenuate biological aging differences between people with and without HIV. So we're yet to see what aging is going to look like in the era of integrase inhibitors. That said, INSTIs have also been associated with increased weight gain, potentially increased risk of type 2 diabetes, which could further accelerate aging. Diabetes is an inflammatory disease. HIV is an inflammatory disease. Cardiovascular disease, inflammatory. Cancer is inflammatory. All of these things in combination, this multimorbidity in combination could further accelerate aging. So continued research is needed to fully understand INSTIs and the metabolic implications, but we also need to really start thinking about lifestyle interventions to mitigate, control weight gain, weight loss, different medications, which are not broadly available here yet, I don't think. But what are some of the things we can do, particularly with lifestyle interventions, to help mitigate some of the increased risk for NCDs? Next slide. Okay, and I don't want to leave out people who have been aging with HIV since they were born. So people with HIV acquired perinatally have shortened life expectancy and higher comorbidity burden than similarly aged people without HIV. We see increased prevalence, at least in the United States. Some places in sub-Saharan Africa have demonstrated higher hypertension rates, diabetes rates in perinatally infected children and young adults than in children and young adults without HIV. Perinatal infection, we know, impacts growth and musculoskeletal development. One thing to consider if you're treating someone who is now a young adult who's been living with HIV their entire lives is that exposure to HIV, that lifelong exposure to HIV could limit bone mass, increasing the risk for osteoporosis and fracture risk in younger people. There's also a higher prevalence of poor treatment outcomes, mental health disorders, and poor quality of life. Anybody who has sat in any meeting on HIV treatment outcomes in the last decade knows that we're failing younger people when it comes to their viral suppression on antiretroviral therapy. It's a significant problem that needs to be addressed, particularly for their longevity and their quality of life. Next slide. So here we go. Sexual partnerships across the lifespan. We're going to talk about the need for testing and prevention programs for older adults.
great.
Here's your poll 3.
This brings us to our third poll question, and
This one should be an easy one, given the case you guys just saw.
so our third poll question reads, older people are not at risk of acquiring HIV. A, true, B, false. Older people are not at risk of acquiring HIV, true or false? Okay. Great participation so far. Please continue participating.
Yeah, that's a good comment. The failure to negotiate.
Okay.
Yeah.
Welcome to the school.
Mhm.
All right, so great participation so far.
Yeah.
Please continue participating. We still got about 10 more seconds. Okay, so I'm gonna end the poll here now. And great results once again. We have 96% that have opted for B being false. Older people are not at risk of acquiring HIV, and 4% that have opted for option A being true. And
Okay, I'm going to speak directly to those 8 people for the next 5 minutes as we go through these slides. No, this is for all of you. So yes, older people are at risk of acquiring HIV. This data, this is about sexual risk behaviors and the fact that they do change over time. It contributes to dynamic transmission risk. All of this data is also from your Xanthias, 2016 and 2021. What you have on the left is Xanthia 2016. On the right is Xanthia 2021. This is data, this is the prevalence of condomless sex among respondents with HIV with a viral load greater than 1,000. So this is individuals with enough virus to transmit to their partners who reported to us that they had condomless sex in the last year with their partners. And your Xanthia 2016 only went up to 59. That was the upper age limit. Xanthia 2021, you had no upper age limit. But you can see the prevalence of condomless sex among people. This is just among people with enough virus to transmit. We have the data on, you all have the data as well, on condomless sex in general. And there's a lot of condomless sex. So, you know, for people with enough virus, we focus on those with enough virus because if somebody's suppressed, U equals U, that's not where transmission is coming from, onward transmission. So this is a vector for onward transmission. And you can see very high prevalence of condomless sex. This is only among people who reported having sex in the last year. These are people who are sexually active. And you can see that there's a high prevalence of condomless sex among older males with enough virus to transmit to their partners who are 55 to 59, 60 to 64, 65 to 69. And I'd also like to point out that the women in the 70 to 74-year-old age group, 40%, had condomless sex in the last year. So go on to the next slide. And this is just looking at intergenerational partnerships. And intergenerational partnerships don't have a fantastic definition. Some people use 5-year differences, some use 10-year age difference, some use 20. We used 10 generally to define intergenerational partnerships, but here we present the weighted mean difference in age between the respondent from Xanthia and the partner they told us about. So it's stratified by male respondents and female respondents, their first partner up to their third most recent partner, and then also by whether the person was HIV positive or HIV negative. And you can see that men with HIV in Zambia, on average, are 8 years older than their most recent partner. They're 10 and a half years older than their second most recent partner, and they're 11 and a half years older than their third most recent partner, whereas men without HIV in Zambia are about 5 years older in general than all of their partners. There is a difference in who people are partnering with based on their HIV status. You see slightly less differences among women, although women tend to have a little larger age difference. They tend to be a little younger than their male partners if they're HIV positive than the HIV negative, but those confidence intervals for the most part overlap, so they're not significantly different from each other. So a lot more similarity in women and their partnerships than in men. So intergenerational partnerships, speaking back to the case study you had today of the 80-year-old widowed man living with a young woman who's taking care of him, intergenerational partnerships may very well still be driving the HIV epidemic, particularly in older people. Let's go on to this. And this one, I think you guys will get the slide so you can spend a little more time with it. But this data is not yet published, so I'm asking you please not to reproduce it or distribute it. This is from our epi of aging, the epidemiology of aging of HIV in Botswana and Zambia. It's our epi plan. This is a grant that I'm working on with Professor Motale at the University of Zambia, where we're looking at sexual partnerships and changes over time to inform modeling for the change in HIV prevalence. So this is changes in partner profiles between 2016 and 2021 among people with a viral load over 1,000. And on the left, you have female respondents to Xanthia with a viral load greater than 1,000. And on the right, you have male respondents with a viral load greater than 1,000. And this is comparing 2016 to 2021. In brief, everywhere it's red, the mean number of partners have gone up since 2016. Everywhere it's blue, the mean number of partners have gone down. And so when we had to cap it at the 55 to 59, because that was the upper age limit of Zamfia 2016, we do also have these graphs just looking at the 2021 data, and people well into their 70s were still sexually active and had at least one partner per year. So older adults are also at increased risk for acquiring HIV due to several factors. So there's misconceptions about risk. Older people may not think that they're at risk for HIV. So much of the messaging is around young people. And we know that still that the highest incidence rates are still in young women, right? So that's definitely the highest incidence rates. But we do still have incidence in older women and in older men. But all of the messaging around testing, prevention is really targeted at younger people, people who are members of communities that are at increased risk, such as people who inject drugs, female sex workers, men who have sex with men. And so older people are somehow unconsciously also told that they're not at increased risk for HIV. This can lead to lower engagement in prevention programs than younger people. There are also biological changes, particularly among women as they enter menopause. Decreased estrogen causes a thinning and reduced elasticity of the vaginal wall. This increases the risk for tears and abrasions during sexual intercourse, and which increases the probability of HIV entry. So there's actual biological reasons why older women would be at increased risk for HIV. There are life and relationship changes. Pregnancy prevention is no longer needed as women get older. So somebody had put in the comment that they may not be able to negotiate safer sex practices, that kind of thing. That very well may contribute as well, particularly when pregnancy is no longer a concern. They age out of the programs focused on women of childbearing age. There are also changes in marital relationships, divorce, widowhood, which could bring new partners in, which requires, testing and having trust about that individual's status. And depression, anxiety, cognitive changes, increased stigma. This can decrease older individuals' comprehension of their own risk for HIV. Next slide. So testing and prevention for older adults. As I've already mentioned, most HIV testing and prevention is focused on people aged 15 to 49. Even in the United States, our guidelines only recommend testing for people up to the age of 64. I think everybody who's having sex should get tested at least once in their lifetime. Most incidents and other surveillance systems do not include granular data on people greater than 50 or people greater than 65. That was a comment earlier by the person with the DoD. Our surveillance systems have not addressed this. So by design, we don't know what incidence looks like in older people. Similarly, programs for key populations generally focused on members of those key populations who are aged 15 to 49, female sex workers, men who have sex with men, injecting drug users, barring early mortality, will be older people that are still parts of these groups. So it's important to keep that in mind as you're thinking about next policies. And so while incidence remains highest among younger adults, prevalence is highest and increasing among older populations. A basic epidemiologic principle is that incidence follows prevalence. So an increase in incidence among older adults is plausible, especially if testing and prevention programs don't reach them or if they're excluded outright based on guidelines. And then integrated care is more than just NCDs. Next slide. Here's your poll question 4.
Great. So this brings us to our fourth poll question, and our question reads: people with HIV are at increased risk of developing cardiometabolic and aging-related conditions due to option A being immune activation, option B being ART, option C lifestyle factors, and option D being all of the above. So people with HIV are at increased risk of developing cardiometabolic and aging-related conditions due to option A, immune activation, option B, ART, option C, lifestyle factors, and option D, all of the above. So immune activation, ART, lifestyle factors, or all of the above. Okay, so
Great to see so many people still participating. Thank you. I'm glad I haven't put anybody to sleep yet. Well, at least
Great.
the people voting haven't.
Great response
Yeah.
team. I'm going to end the poll question here and sharing with you the results, Prof. Kristen.
Yep.
We have 90% that have opted for option D, being all of the above, 3% for lifestyle factors, 2% for ART, and 5% for immune activation.
Great.
Yeah.
The good news is with a question like that, everybody's right,
Mhm.
because it is all of them. So if you pick one of them, that you're also correct. So there's been a lot of talk. There's been a lot of talk through PEPFAR through the last few years. There's been a lot of talk through the WHO for the last 3 years about integrated care. And this is important for everybody. So older people is one thing. Aging is something that we're all doing every day. And trust me, you'll become more acutely aware of it the older you get. So aging is something that we are all doing. And when you do it right, you do it for a really long period of time. But older people with HIV are at higher risk for cardiovascular disease, renal disease, lung disease, metabolic disorders, type 2 diabetes, than the general population currently. But the rest of your population also is at increased risk for these things because of the changing in your society. We've seen people in general are living longer in Zambia. There are changes in diet. There's changes in exercise with increased urbanization. There's just changes of some traditional things that had really protected populations from diabetes, cardiovascular disease, and that kind of thing that are changing on a daily basis. While guidelines for integrated care of NCDs into primary care exist, models for successful implementation are highly limited. There are providers and clinics that have been focused on HIV for decades, and they may have less experience with clinical care, pharmaceutical management for NCDs. Limited subspecialty providers also present challenges. And effective prevention and management of NCDs can delay the onset, and it can mitigate the severity of aging-related conditions, which is one of the reasons that thinking about integrated care for multimorbidity is important. Go ahead, next slide. So I'm going to introduce the topic of multidimensional geriatric assessment. I hope those of you who are going to be able to attend Professor Orwig's talk on Wednesday, where she talks about gerontology specifically, we'll get more detail on this, but the idea of geriatric assessment. So, when people talk about geriatrics, in the United States, we're talking about people 65 and older. I work with a number of other programs in sub-Saharan Africa, and we've had to tone down the geriatric language because they're talking about geriatric care among people who are 40 or people who are 50. And that very well may be what's the truth for this setting, as opposed to the United States or Europe. But it's important to understand that geriatric assessment, when we talk about assessments, we're usually talking about screening. But in the context of gerontology, geriatric assessment is more than just screening. It's assessment, but then it's management plans for the drivers of those conditions. It's operationalization of those plans. How do you actually implement it? And these things cover functional ability for cognition, physical function, things like mobility, nutrition, vision and hearing, psychological capacity, social support, caregiver networks. And it provides really important information on patients' ability to perform basic daily functions, assess threats to independence, as well as polypharmacy. And they incorporate an understanding of what's important to the patient and what their health and life goals are. Next slide. So there are a couple major frameworks for this. One is the WHO Integrated Care for Older People, ICOPE. It's everybody is entitled to their opinion. I prefer the next one, the 5Ms framework. So this is multi-complexity, mind, mobility, medications matters most. And the table you see there is from our geriatric society in the United States. These are the minimum competencies in geriatrics for medical students. So for medical students to finish, to be able to pass and become doctors, they have to have these minimum competencies in seeing patients. So it's something to consider. It's something that I hope you'll talk to Drs. Mundia and Dr. Neal about, because they just spent a year doing this with their patients in their clinic, trying to get an understanding of what the 5Ms look like in the patient population here at UTH. Next slide. And this leads me to the idea of the fourth 95 and the need for something focused on quality of life. As epidemic control is approached, achieved, and maintained, epidemic control is not static. You can lose it. It's important to maintain it. Health systems are really going to need to accommodate not just NCDs, but geriatric conditions and interventions to support quality of life in people aging with HIV and people aging in general. There's limited data from Africa on physical function, frailty, cognitive decline, although Professor Mata is doing a great deal in the dementia area. It's a rarity in many settings. What we also especially don't know is how these factors impact quality of life in Africa and whether there are cultural or other factors that might mitigate or exacerbate aging trajectories. It very well may be that the context of Zambia means aging looks different in Zambia than it does in Europe, the United States, Japan, South America, and it's important to understand. We know there's limited data on integration. We know there's limited data on moving people with chronic conditions into primary care, and there's limited models for geriatric care. Last slide, I believe. So some closing thoughts for you and your context. Life expectancy at birth has increased 16.4 years in Zambia since the year 2000. That is a massive, massive increase in life expectancy. Remember, this is life expectancy at birth. This is not life expectancy for people who have already achieved the age of 40 or 50. That can be longer. So you have somebody who makes it to 30 or 40 or 50. They might have another 30 or 40, 50 years of life. All of you can think about a grandparent or a great aunt or your own parent now who is in their 70s or 80s or 90s. This will continue to increase. As people with HIV live longer, care systems and care providers have to address multi-complexity will be critical to preserving the gains you've already made in controlling your HIV epidemic. As the general population of Zambia ages, they too will benefit from multi-complexity models of care. And as lifespan increases, it's critical for all of us to focus on an equal increase in health span and quality of life. Si como? Oh, last one. Sorry. I had to do another poll question. We'll do that quick.
So last poll question. Sorry, let me just launch this. Okay, so our last poll question reads, it would be easy for me to ask my patients about challenges they have with daily activities during routine visits. A being yes, B being no.
And think about daily activities as things like, do you have difficulty going to the bathroom? Can you get up out of a chair by yourself? Are you able to go to the market and get your food? Are you able to fetch water if you're in a rural area? Start your cook fire if you're in a rural area. Basic activities of daily living.
Great. So would it be easy for you to ask your patients about challenges they have with these same daily activities during their routine visits to you? Yes or no?
It's a lot of yeses. That's good.
Okay, so we've got 90% that have opted for option A being yes, we do ask, and 10% that said no, you don't usually ask.
Be higher.
Yeah.
Already so busy.
Yeah.
Right? There's so much you have to do in such a short period of time. That's good to know.
All right, great. So this brings us to the end of our presentation for today. Tototela Zikomo Talumba, thank you from Prof. Kristin for this, for your contributions and for paying attention. And so now we're going to open up to a Q&A, and we also have our panelists. We have Dr. Mata, we have Dr. Prof. Orwig, who's a gerontologist. We have Dr. Mundia, we've got Dr. Sinyangwe here, Dr. Kawaso, who jump in to help us answer a few questions. So just jumping into the chat box. If you do have any questions, kindly raise your hands and we'll be able to check them up. So just quickly reading what's in the chat box so far. We've got a very nice comment from Dr. Ingwira Agnes. Are healthcare workers shying away from testing older patients due to culture? I think this is still very important. It does get very difficult to ask somebody older than you about their sexual history.
Yeah.
And I think we need to shun away from such practices. Now, the fact that we are healthcare workers, and it's important to screen them thoroughly. Then a comment
Just
from
another
Yep.
comment on that, though. Is that some of it is also the way you're funded to provide testing. If you're asked to do a risk stratification, and is the person of a childbearing age, or or if you only having to report on 15 to 49-year-olds, that disincentivizes people to even think about older people getting tested.
Right.
And
Agree.
misconception of elderly people not engaging into sexual practices or them being at risk of HIV acquisition. And also culture also plays a very big role in it, in the sense that most elderly people do not expect to be asked questions around sex
Yes.
and things like
Yeah.
that. So
Yeah.
it becomes a little bit difficult for health workers to actually bring that up. But it's something I think as Minister of Health, we have to strengthen and encourage that testing should go beyond, like you have said, beyond 49 years of age. And I think we have tried to strengthen that by encouraging everybody who comes to the health facilities to ensure that they are tested at any point when they have any entry, whether it's OPD, under 5 clinics, immunizations, if it's the ANT clinics. So I think that's very helpful if we strengthen that, and we'll reach out to more for testing.
Yeah, thank you, Dr. Mundia.
Thank you.
It's a good question.
So we've got a question from Mr. Sindala Mbita from Botswana. Thank you for joining us from Botswana. Mr. Sindala is asking, what factors contribute to the higher HIV prevalence among older adults aged 60 to 64 compared to the younger adults aged 25 to 29 in Zambia? And how should this influence our public health strategies?
That's a fantastic question. So the same is true in Botswana. The prevalence of HIV is far higher in older adults than younger adults. And so I almost put in a slide on a reminder about prevalence. So prevalence is everybody currently existing with the disease. Incidence feeds into prevalence. Those are new cases coming in. And the only way cases come out really for HIV is through mortality, because we don't have a cure at this point. So the reason HIV prevalence is higher in older age groups is multifactorial. People are living longer, so they're aging into those older age groups already with HIV, and you're reducing your incident cases among younger groups. So you don't have, even though incidence is higher in younger people, the denominator in younger people is far higher than it is among older people. So prevalence is just a proportion. How many in a group have something? So because of how long the HIV epidemic burned in Zambia, in Botswana, in Southern Africa, and then what a good job done of getting everybody tested and on treatment, they're aging into these older age groups. And the last contributor is increased infection among older individuals that are contributing to that higher prevalence.
Thank you so much for that, Prof. Kristen. We've got a question from PK, and this is in regards to support available for such patients who usually have mobility issues or social issues, and there's no support available. So what do we do for them? And this is a great point. I think this is a very massive problem of what actually happens in our setting. And I
that's
think
a rule of thumb, right?
Yes.
We don't screen for things unless we can do something about them. It's just not ethical to screen for things that you can't then do anything about.
It could be an impetus
That's
to start a conversation. So if
Exactly.
you start asking real correct questions, you realize that a lot of people are experiencing problems. That could be a way, right?
to advocate for services.
Resources and supports could be made of it, right?
Yep.
So I think until we know
what the burden
To
is.
start asking questions, I don't think we'll know for sure.
Yep.
And if I could add, I think
Yeah.
that is, especially at the primary care level, something brings people into the hospital setting, especially older people. So if we do not spend time asking them what are the main problems, they will keep coming back and we're not really getting to the root cause. And even though services are very fragmented, a lot of the times you find that there are things that we can do. Mobility issues might require us to involve, we might not have a lot of occupational therapists, but we have physiotherapists in most government settings, and they are able to give some advice and guidance in terms of what walking aid should I use instead of that stick with no rubber at the end that is increasing your risk of fall. Let's try to get these things. So we have to work with the little that's available, whether that is mobility assistance. There are some social welfare resources that are available. They're not always easy to get into, but at least if we're able to identify what the need is, then we can be a bit more focused in providing care and support.
Absolutely.
Thank you so much, Dr. Mata. That was Dr. Mata, our neurologist and our dementia specialist. Thank you for that contribution. We do have a number of comments that say great presentation.
Thank you.
So thank you so much for your lovely presentation. Any questions from the chat box? Any hands raised? We've got Prof. Cassidy on, who's one of our panelists. Would you like to say something, Prof. Cassidy?
Hi, sorry, can you repeat the question, Neil?
Oh, so we're in the Q&A session now. So just wanted to ask you if you've got anything, if you'd like to contribute to the discussion around HIV and aging.
Yes, thank you so much. And I just want to.
I know most has been covered.
I know everything has been covered very well by Prof. Kristen and Prof. Orwig. First of all, I just want to appreciate Dr. Stafford and Dr. Orwig for making the trip to Zambia and for presenting. Thank you so much. It's great to have you be part of this call. And just to reiterate the items that have been covered here about the very real concern about HIV and aging in older people. I just want to briefly relate one story I actually had in America. I had a 78-year-old man who had gone on vacation and came back with acute HIV. So we see older people getting HIV in the US, in Zambia. Older people are sexually active. We need to keep that in mind and treat them as we would any other people, bearing in mind all the key elements that Prof. Stafford has brought out in her talk here. So I'm very excited about the research work that we're doing with Neil and Mundia and Prof. Stafford and Prof. Orwig, and we're looking forward to disseminating those results later when those are available. Thank you so much. Great presentation. Wonderful to be part of it. Thanks.
Thank you so much, Dr. Klassen. Any other questions? So we've got Faith Kamanga.
It's a great question.
Is managing OIs in the elderly any more challenging compared to younger patients? That's a really good question. Anybody in our room would like to answer that? Dr. Karaso, Dr. Sinyangwe, Dr. Mwanza?
Is it any harder for crypto, toxo, any KS?
Maybe let's say comments to say that you find that the majority of the elderly patients, in the first place, they may know their HIV status, but they haven't disclosed their partners. And because of that, the compliance is a problem. So at the time they present, you find that the majority of them, they present with the advanced HIV disease state, which also means that in terms of attention, and of course, they are elderly people, they need a bit more attention and also putting in the factor that their other organs are also at risk, maybe for certain drug dosages. So you find that they need a bit more attention. But in terms of, I wouldn't comment because we don't have statistics like in our country to say the elderly people and the young ones comparing to how quickly they respond to treatment, those that are presenting with AHP. But there are just few things that we need to pay particular attention, especially when we're attending to the elderly people that present with these infections. Thank you.
Great, thank you, Dr. Karaso. So It does get challenging because we don't have any statistics, but screening, managing OIs depends on the complexity of the patient, as Dr. Karas has put. Remember about drug toxicities and so on in these individuals. Any more questions or contributions? Kindly feel free to unmute yourselves and ask away. Yes.
Something for food for thought, Prof. Christine. In addition to the biological changes for our elder women that are at risk of HIV physician, is as they go into the menopausal phase, the pre and the menopausal phase, they tend to experience vaginal dryness.
Yes.
And that
Due to the
actually,
estrogen decrease.
yes, that actually increases their risk.
It does of actual acquisition because the vaginal lining actually gets thinner
Yes.
and it loses elasticity. There's increased risk for abrasions and tears, which increases the probability of transmission of HIV, as well as other infections,
Yes.
other STIs, and it also increases the risk for bacterial vaginosis, which is a contributor to an increased risk in general at any age of acquiring HIV.
Yes. So also something that from my experience, especially in the prevention clinic, not only just looking at the older population, but there has been I'll call it a cultural practice in women that would sweep their membranes. And of course, there's been different studies like Uganda and Kenya that actually looked at vaginal sweeping and led to increased HIV infections.
Yes.
Unfortunately, it's becoming a common trend now, even in our younger women.
So like chemical douching or
not only chemical douching, the traditional sweeping with
with a cloth.
There's all sorts of substances that are being sold on the streets that would push up into the vagina to have a dry vagina. But this is not only coming from the woman, it still comes back also with the partners wanting to have that experience. And again, that demand is still coming from the older men.
Yes, to the younger women.
It's something that also we have to look into, besides just the complexity of menopause, but looking at what are the preferences of individuals. And you'd find that some of the risky behaviors mostly will come from the older population, either from the older women or the older men. So again, coming to discussing some of these matters with the recipients of care or patients as we engage with them, we will still need to highlight some of those.
Absolutely, you're absolutely right, Dr. Mundia. Thank you for that.
Excellent. Thank you, Dr. Mundia, for that contribution. We do have a hand raised. PK, kindly introduce yourself and you may go ahead and ask your question or give us your contribution.
Hello. So I am calling from Flira in one of the urban areas, rather the rural areas.
Great.
So I was just wondering, like, with regards to management of the NCDs and HIV, you'd find that in rural areas, it's being done separately, whereby if someone they're HIV positive, they've got diabetes and hypertension, it's not being managed under one clinic. It's HIV is being done under ART clinic, and hypertension and diabetes is being managed by other clinicians. So if there was a way of bridging management of HIV and NCDs, I think that would also kind of like help out, especially in the elderly population. I do believe, in bigger hospitals, they're doing that, but the issue is with rural areas. Yeah, thank you.
Yeah, it's really difficult. Yeah, PK, thanks so much for that. And I'm probably going to commit heresy and lose my ability to continue working in this field. But I don't think integrated care is the answer for everything. I think knowledge among providers to be aware of other conditions. We don't have fully integrated care in the United States. I don't get my primary care and any specialty care at the same clinic when I go. We've done this particularly in the HIV space with co-located cancer clinics, co-located NCD clinics because of the interplay, the multimorbidity interplay, and the importance of because the HIV and the HIV treatment isn't causing these increased burden, trying to make sure that both of those things get addressed in as few visits as possible to increase adherence, particularly the HIV side, has been part of this. But I agree with you. I've worked in rural areas here in Zambia, and I don't know how they would do fully integrated care when there's not even enough specialty services available. But I think that's where conversations about what would work in your setting for your patients and trying different methods are important. There's been a lot of good work over the last few years on training lay individuals to get blood pressures during home visits for adherence visits or through differentiated service delivery models. But the context is important, and the answers that are going to work in Lusaka are going to be very, very different than the answers that are going to work in Kitwe or someplace else in rural Zambia. I don't know if others want to add to that.
I agree. I think one of the things I've always loved about the HIV program is if you are if HIV positive in this country and in most countries, we will take care of you. We will monitor you very, very closely. Unfortunately, the same thing does not transfer if you are HIV negative.
Yep.
If we could pick some of the really great models and simple tools like just having red flags in non-communicable diseases, that would trigger certain things so that even if I'm a lay person and I'm doing a blood pressure, if I see this kind of blood pressure, it should prompt me to do this next thing. I think that would be very, very important in the management of non-communicable diseases in the HIV negative space, the same way it's already being used in the HIV positive population. But integration, especially where you don't always have the people that you need to be able to run a really integrated clinic, you have to decide what do we need in this particular space, what works for us, like you said.
Agree. Thank you, Prof.
Great. Thank you so much for those contributions. And just other healthcare workers like PK in these rural setups where NCD care isn't integrated, we do have the advanced HIV disease guidelines easily available on the internet as well. And it does have an algorithm, treatment algorithms for the management of common NCDs like hypertension and diabetes. And the current AHD guidelines are undergoing an update, but those guidelines that are there right now are good to use. So I'd advise anybody in a rural setup where access to specialist care isn't available to use those guidelines to treat these NCDs. Thanks, PK, for that. We're going to take this last few comments. We've got a comment from Paul Mwale. This is a very good presentation by Prof. Christine, but screening for geriatric syndromes have been a challenge, partly because of lack of experts in geriatric medicine, as well as our guidelines not giving special focus to the special needs of our older patients living with HIV. Financial support tailored to this group could be a challenge, and of course, lack of screening tools for geriatric syndromes. And I think this is a very, very important comment. And thank you so much, Paul, for this comment. Yeah. And I think there is need, maybe not at our level, but at ministry level, yes, to now focus more into geriatric care. I believe Prof. Orwig mentioned that geriatric care, even in the US, is a little challenging in terms of people specializing in it. Would you like to comment on geriatric care?
Yeah, so we're going to talk about it on Wednesday for sure, but where we've been least successful with geriatric care is in inpatient right? So we have multidisciplinary care teams, including geriatrics, that meet patients and develop a care plan while in the hospital. That's not to say it carries forward once they go back home, but it's a starting point. The other thing might be your policy issue, which you might want to think about, is that
Oh, they're not hearing you. Hold on. Thank you.
Hear me now? Yeah. One policy issue that you could think about that I know is happening in the United States in particular. Remember, we have a different healthcare system than you do, but we do have a Medicare system that does cover health insurance for all older adults, 65 and older. And one thing that's now being required, it's going to become requirement, is for anybody that enters the hospital to get a certain level of reimbursement from Medicare, they have to have age-friendly care plans in place. And so what does that mean? They're not defining it, but there could be ways for you to approach your Ministry of Health, for example, to say, look, when I'm managing an older adult, I need some extra insurance reimbursement, right? So maybe you get I don't know how your system works, but maybe you get an extra 15 minutes or something where you can consult with them so that you can manage their comorbidity complexity. So it's just a starting point to think about how can you make that happen, because it isn't going to work unless you get that time that you need, right, to coordinate that care. So just a thought I was having.
And just
while you were asking the question.
Yeah, thanks, Prof. Orwig. I think just to add, Dr. Moale, I think it's also important to remember that programs follow policy, and policy is driven by demonstration projects, right? So an understanding of the prevalence of the problem, demonstrating how you might be able to address it, and then policy follows, and then programs follow those policies. And it will absolutely be challenging to do these things when you have a resource-constrained environment, and particularly in our current environment, given the changes that have come from the United States commitment to funding. There are going to be really tough questions that you're going to be asking, going forward. And this is yet another one, asking one of these things. But I would just emphasize that programs follow policy. So without a unified policy on care and health span for your aging population in general, and then for your HIV population, I'm not sure programs will develop without that.
All right, great. Thank you so much for all these comments. We've come to the end of our session.